First, I'd like to introduce to you Dr. Greg Waybright. Dr. Waybright is President-Designate of Trinity International University. He will officially become the president this September. So you will be seeing plenty more of him if you are around these parts in days to come. He received his PhD in New Testament theology from Marquette University. He also received his MDiv from Trinity Evangelical Divinity School, an MA in Communication from Wheaton Graduate School, a BA in Biblical Studies and Philosophy from Wheaton College, and the Diploma in Pastoral Studies from Moody Bible Institute. He has a rich overseas experience as well. For more than 4 years, he served as music director and soloist for the Günther Tesch Evangelistic Association, headquartered in Hamburg, West Germany. This mission work provided ministry opportunities throughout Western Europe, Scandinavia, and India. And since 1988, he's been the pastor of Arlington Heights Evangelical Free Church in Arlington Heights, Illinois. And in his 17 years as pastor, he's served pastorates in California and Wisconsin, as well as Illinois. Dying has been a real part of his experience of pastoral ministry. It's been a real part of life itself. So Dr. Waybright, it's a real privilege to have you here with us and your willingness to share with us today.
Just realize, said George Wald from Harvard, a Nobel Prize recipient, I am 69 years old, and I have never seen a person die. Imagine it. The most dramatic event of human life has been taken out of my experience altogether. I tell you, that testimony is not unique. I imagine that most of the people in our society have never seen a person die. I've even found as a pastor that most of us in our rather success-oriented world try to ignore the issue of death altogether. Haven't you seen that many people don't even want to use that word death, opting for euphemisms like passed away or no longer with us? It used to be in our society that people experienced life and death in the same house, sometimes even in the same bed. Personal experiences with birth and with death happened in the normal course of family life, but no more. Now, apart from certain movements like hospice, death is confined often to terminal wards or old folks' homes. I think it's rightly been called the universal human repression of our day. But that's not been my experience. I think one of the painful privileges of being a pastor is that I have come into contact with death so often. In my first month, my first week of being a pastor at age 26, I did 5 funerals. Throughout my years of being a pastor, I have met with grieving people again and again, both Christian and non-Christian, religious and irreligious, old and young. And yes, I have seen people die, including my second daughter. I was holding her in my arms on a Sunday evening 11 years ago when her death came. Because of that event, I can no longer view this matter of death simply as a professional matter for which I am trained. I feel it in a way much more personal than I ever did before. I think for me, in sharing with you an experience of dying, the problem is that death feels so final. And I think that at a conference like this one, where so many of us have been trained to deal with people who are wrestling with that finality, I have learned, perhaps as you, about how to cope with it and help other people cope with it. I've learned how to identify the stages of grief. I've learned the phrases that I should express and those that I should never allow to come out of my mouth. But I have found that the problem with death is that it confronts us in such a personal way. Death is a certainty unless Christ comes soon. Death is going to come to me. To me. So that as a pastor, I can do what a pastor does, or as a caring professional does in saying the right phrases and helping people cope with death. But I have found that now I no longer can maintain very much emotional distance because I have seen death and because I've had to face the fact that it's coming to me. Therefore, when I try to share with you a pastoral perspective on death, I have to tell you I first must come to grips with the fact that someday I will die, and you have to do that as well. I mean, I have conducted so many funerals, but someday someone is going to conduct mine. I have counseled with so many people at times of death, but someday I'm going to be the dying one. What then? What do I really believe? Where will I be after I die? Let me tell you, if death is the end of everything, then you see that life is futile. It's crazy. It is an unjust charade. If death were just an ending, I think it would be something we'd have to view as a blank wall against which all of our aspirations are shattered hopelessly. Just think about it. Our tenderest memories, our greatest achievements, our deepest relationships. What would be the point of those things if we are simply to be annihilated and erased from existence? People do so many things with the enemies of human beings in our world through technology and through science. We find ourselves defeating many enemies of society, but if that last enemy, death, is a final termination, then human beings are always going to be slaves to that unstoppable fate that casts its shadow over everything we do in our world. Now, with all that in mind, I want to say very clearly that this is one of the reasons that I love being a minister of the good news of Jesus Christ. You see, for us as Christians, and why I love to team with the Christian Legal Society and Christian Nursing Society and Christian Medical Society, is that we know that this mysterious enemy called death no longer is something that we have to know so little about. We as Christians don't have to speculate about death as being something that is just in the realm of guesswork. No, because it has been taken out of that realm of speculation and put into the realm of fact. Something we know has happened in history that's changed everything. What is it? It's Christianity 101. Jesus Christ died and rose again. And let me tell you, for the early Christians, that was no legend or myth. That was a historic reality. It was witnessed by hundreds of eyewitnesses. Moreover, those same Christians had heard Jesus say that he would promise to all who follow him our own resurrections to a place, as Paul would put it, that is better by far. When you read the New Testament, belief in those things made it so that people like the Apostle Paul would view this enemy of death as being something no more troublesome than like being a mosquito that you just swat away from your brow. Do you remember what he said? Where, O death, is your sting? Where, O grave, is your victory? No, I believe that. Having said that, I want to tell you that even though I believe it with my whole heart and proclaim that message to a dying world, that there is life beyond this life, I want to say that at the same time, I have found it sometimes so hard to communicate the hope and the confidence that comes to that in a way that my people, my parishioners, feel it and experience that hope. I believe that Christ makes a difference in every part of our lives, and especially we see it at that time of death. But I have to qualify that by making a couple of statements, 3 of them. It's what pastors always do. Number 1, I have found that Christians and non-Christians alike experience sorrow and pain in the face of death. That pain is what C.S. Lewis described so graphically in his book, A Grief Observed, which was really simply his diary that he wrote in the months following the death of his wife. It's the same pain and sorrow, and I'll tell you, anger, that I often felt when, at the death of my daughter, people would come and say something like this: well, Pastor, aren't you rejoicing that your little one is now in the hands of God? Well, no, I wasn't rejoicing. I wanted to touch her. I wanted to see her, and I wanted to hear her in this world. See, the difference that Christ makes is not that there is no sorrow. It's just that our sorrow is not a sorrow devoid of hope. We, as Christians, miss that person who has died. We long to be with that person that we love, but we are confident that it simply is a temporary separation. I love the way that the apostle put it to the Thessalonians. He says, at times of death, we do not grieve like the rest of people who have no hope. We grieve, but it is not a hopeless grieving. It is hope-filled. Statement number 2. I have found that Christians and non-Christians alike often have no sufficient answer to many of the why questions. When people come to me, as happens so often, and they're dealing with untimely deaths, I often try to say something like this. If you're expecting me to give you soothing, pat answers to why did this happen, you've come to the wrong person, because I still ask those questions myself, even though some of my parishioners tell me I shouldn't. When I talk about this, they often say you shouldn't ask why. But I find biblical writers asking that question, and it's a part of my ongoing relationship to God as my Father. I guess I've become convinced that if that is the question that is in my mind and heart, I must ask it candidly if my relationship to God is going to be a relationship of openness and integrity. So I'll tell you, I do ask, why did that young, godly high school boy drown at that church camp when he was trying to save that young, struggling camper? Why did my brother die at the age of 43 instead of that drunk driver who hit him? Why did that father of 3 young children in my church die of cancer and leave that family? Why did my daughter die before her life had hardly begun? I tell you, I have never found adequate answers to those questions. But I wrestle with them, and I tell you, I am still at peace. I've learned to cope because of one simple word, and that word is trust. As a child, I had to learn to trust my parents when they forced me to do things I didn't want to do. I remember when they forced me to go to school and I wanted to stay at home. When they forced me to go to the hospital doctors for those respiratory problems I had as a child. And then, after I had received my PhD in theology, just a few months before my daughter died, it was so humbling for me when in the face of that pain, I was reduced to simply asking this question. I don't understand why, but do I trust God? Do I trust that He's good? Do I trust that He is in control? And am I willing to wait for Him to do something that I cannot see? I became a Christian through childlike faith. And in experiencing death and dying, I have learned that we must live day by day as Christians with childlike faith and trust in God. Isn't that what Jesus said to the disciples? I am going, I am going. They couldn't understand it. Then He would say, don't let your hearts be troubled. You trust God, trust me. I know what I'm doing. It's Christianity 101. We give our lives to Christ. We believe He knows what He is doing. We wait for Him to do it. And my testimony simply is that I've discovered that He is worthy of that trust. Statement number 3. I find that this hope and confidence and peace is never experienced by people whose focus is this worldly, whether Christian or non-Christian. Especially, it's not experienced by narcissistic churchgoers obsessed with personal health, personal success, and personal prosperity. I'll tell you, there seem to be so many people who feel like if I go to church and don't smoke and live right and pray right and believe hard enough, then things like sickness and death will never come to me. How can anybody who follows a Lord who went to a cross believe such a thing? But many do. I'm convinced that many in our success-oriented society have never grasped that the purpose of a Christian's existence is neither simply to live or to die, but to honor God in whatever happens. Paul understood that, and he could say, for me to live is Christ, and to die in many ways is even better, because it will take me to a place better by far. It's a Waybright paraphrase. Frankly speaking, I run across so many religious people who, by their obsession with healing and wonders, lose the ability to honor God in the way that they die. Instead of simply trusting their Heavenly Father and accepting death triumphantly as simply one more step in the purpose of God for His people, I find a hysterical search for a miracle healing, as if it would be quite impossible for a Christian to die. And the result has been that instead of a courageous testimony, there is an attitude that to the world looks no different from cowardice. But for those of us who believe in the message of Easter and who trust God even when His purpose isn't clear, there is confidence in the face of death. So that's the word Paul used in 2 Corinthians 5. I am confident, I say. I am confident. I'll tell you, that word confidence is not a word that I've been able to use very often at a non-Christian's funeral. At those many services and wakes that I've been involved in, I hear people wanting to talk about the casket, the beauty of the flowers, how well the mortician has done his or her work. Doesn't he look natural? Isn't she beautiful? And not being able to face the real issue. Death has come. Where is he or she? You know, Christianity has often been called a crutch for the weak by its critics. But as a pastor who comes face to face with death so often, I know how wrong that criticism is. I have learned that faced with the reality of the grave, it is the genuine Christian alone who does not have to run away. We can look death right in the face and offer hope to a dying world because we believe in a Lord who is risen from the dead. Earlier this year, I had the privilege of meeting with Pastor Andrew Furiyama, major leader in our churches in Japan. He was in his hospital bed suffering from pancreatic cancer, and a few days later he would die. But I'll tell you, on that evening, that dying man was so much alive. I went to encourage him, and all that happened was he encouraged me. He said, "Brother Greg, this is the message that you and I have learned so well cognitively, but I am telling you it is true and it is practical. I stand before my death and I am not afraid, because Jesus said, I am the resurrection and the life. He who believes in me, even though he die, will live." I thought of how different that was from a documentary I saw in Great Britain while I was doing my doctoral studies. It was a BBC production called Sea of Faith. In it, pastor and theologian Don Cupid was telling of a time when he, as a young priest, was assigned to go to visit a dying man in a hospital. Though he was a theologian and a pastor, Cupid was and is agnostic. Cupid said that as he went to that hospital room, the man was obviously in his last hours, and as a priest, he took his book and he read the appropriate words and he prayed the prescribed prayers, but before Cupid left, the man died. As he was going home, Cupid reported, "I didn't suppose that my words had magically altered the eternal destiny of the man, and yet I felt it had been worthwhile turning out. And I hoped that when my time came, someone would do the same for me. I learned that day that religion is a way of affirming human dignity in the face of an indifferent universe." The screen comes down. Though eloquent, his words left me empty. Is that all that we pastors have to offer to a dying world? Will that message offer hope to our world in this 21st century that certainly will bring with it many terrors? The pastoral perspective on the experience of dying. Which of those two pastors do you want to have visit you when you're on your deathbed? Furiyama or Cupid? It's not a hard decision for me, I'll tell you. Jesus does not merely offer us an affirmation of human dignity. He offers personal access to eternal life with God. That is the message I proclaim as a pastor. That is the hope I have to offer. When I die, I don't need a clergyman affirming my dignity. And I'll take any one of you coming to me and simply reminding me the words of Jesus. He who believes in me will live even though he dies. For I, your Lord, am the resurrection and the life.
It's a delight now to introduce to you Arlene Miller. She's Associate Professor of Nursing at Messiah College in Pennsylvania. And there she teaches an integrated curriculum in the baccalaureate program. The focus of her teaching is in the area of theory and ethics, chronic illness, trends in nursing and community health. Her clinical teaching addresses areas of medical, surgical, home health, and the emergency department. She received a diploma from the Altman Hospital of Nursing, and then she earned her BS in nursing at Case Western Reserve University in the Francis Payne Bolton School of Nursing. Her MS was earned at the University of Minnesota School of Public Health with a major in public health and a minor in public health nursing. She received her PhD from Temple University, the Department of Religion, where her dissertation was on the topic of becoming good. Her publications include articles in such journals as Women's Concerns Report and Journal of Christian Nursing. She's presented papers and workshops at numerous conferences around the country, but even more significant in a way than those various academic achievements is the fact that she has a keen eye and heart for people's experience. And that experience includes the experience of dying. It's a great pleasure to have you with us here today.
I want to say that the temperature has stolen my opening line, but I'm going to give it anyway. Ethics discussions take place in air-conditioned academic settings. Ethical decisions are made in crowded living rooms full of people who are tired and wondering what to do next. I want to tell you of one family's experience of facing death. I want to take you with me last spring when I was with one of my senior students. And we were going to visit a family in Steelton, Pennsylvania. Steelton's just what it is, a steel town. Republic Steel, for many years, formed the backbone of the economy of that town. It's one of my favorite towns. There are people there from many ethnic backgrounds, many Eastern Europeans who came there to work in the early part of the century in the steel mills. And more recently, during the Second World War, many black families who moved up from the South. We were going to see one of the latter families. We entered the home of a modest frame home hanging to the side of the hill because Steelton literally hangs on the side of the hill beside the Susquehanna River. And as we entered the house, immediately we moved into a living room where Grandma was in a hospital bed. The room was not small and just adjacent, or not large, and just adjacent to that room was a very crowded dining room that had the furniture that had previously been in the living room where Grandma was now laying. And in that room was the woman's son. He was retired, having spent his life working at Republic Steel. And his wife was there, who I very quickly picked up was the caregiver. In fact, the son himself was a partially invalid. So here was Grandma. We were going to see her to do a, quote, routine follow-up after her discharge from the hospital. She'd been discharged when her days on Medicare were finished. And she was sent home with end-stage congestive heart failure, meaning that her heart was in a failing stage, and the best that could be done for her was to maintain her as long as possible on medication. And what we were to do was to check her blood pressure and make sure that she wasn't having swelling and that she was eating and so on. Now the family, especially the daughter-in-law, was not really happy to see us because we were one in a string of many people who had been in and out of the house. It isn't like it used to be when I did visiting nurse work years ago. We had what we called continuity of care then. That hardly exists anymore because of the economic pressure, as it's whoever can get into the house. And here were two of us. She'd never seen us before, and one a young student. Now, usually I let the students take over in these situations because it's their visit and I'm there. I try to not be a bump on the log and, you know, I chat a little bit with the family, but I very quickly perceived that this was something that I had to enter into. The major concern was that Grandma would not, could not, would not swallow. In fact, they had been trying to tell people in the hospital, they said, we've tried to tell them she can't swallow. She cannot take fluids, and I very quickly saw she was not swelling, she was dehydrated. And she couldn't take her medication. And everybody had just said to the daughter, just keep trying, keep trying. And with the parade of people through the house and the busyness of people in the hospital, nobody had really taken this concern seriously. So I thought, well, let's try. We got some fluid for her, and in truth, I still don't know. She could not, would not. She would not talk to us. She was sitting up when we were there, but we helped her then to move back to the bed, and the student went ahead and did the routine kinds of checking of her vital signs and so on. I don't know whether Grandma really couldn't swallow. My hunch was maybe she'd had some little strokes and truly couldn't swallow. And I need to tell you that this whole experience reminded me of my own family experience where my mother cared for my father for years. And I knew personally the frustrations with trying to deal with people who could not or would not listen to the particular problems with which we were dealing. Well, I agreed she was not taking anything. She couldn't take her medication. And then then the family was worried. What are we going to do? Grandma can't swallow. She can't eat. Eating, drinking, two basic things people have to do. How do we get fluids in? Well, I went over about 4 ways. You know, you can put tubes in. You can put tubes in veins. You can put tubes down the nose. You can do an incision, put tubes in the stomach and put it in that way. You can put in another incision and put in what's called a central line, big tubes right into the major veins. Well, son was not impressed with tubes because Grandma had pulled them all out in the hospital. And furthermore, he himself, from his own past experience, had been hospitalized and he had had tubes in, and we agreed if we were going to leave tubes in, she'd have to be restrained, and he did not want any part of that because he had been restrained and he didn't want his mother's arms tied down. Well, so what do we do? Here's daughter getting pushed. Keep trying, get the medication in, and well, maybe you can't take care of her anymore. Maybe you need to put her in a nursing home. Well, they didn't want to think about that. They had brought her from a few blocks nearby some months before when she started falling. So she was out of her own home and had moved in to this house. Well, I finally called the physician, who apparently had not seen her since she was home, and I didn't know him, and I didn't quite know what the situation was, but I told him what we were finding. It seemed that she couldn't swallow. Well, he was not sure. He thought perhaps she had some problem with the medication that was making her nauseous and she wouldn't swallow. Well, it seemed a bit dubious to me because she hadn't been taking it, so I didn't know, you know. In any case, I also picked up that in all of this, the son was kind of giving directions, but I put my arms around the wife, and I said, I think this is a very tired lady, and the tears came. While she said she didn't have to get up at night with the woman, she heard every move that the lady made, banging on the side rails, making noise. She was exhausted. The son wanted what was best for his mother. Meanwhile, in all of this, their son, the grandson, entered the home. So now there were 6 of us in the house. Because he had been worried also about Grandma and not eating and what we were going to do and how we were going to take care of this problem. And then shortly after he came, the pastor came. So now we were 7 in these 2 crowded rooms. And the pastor came to give communion to Grandma. So he was giving communion, and somebody told him I couldn't pay attention to him, and to me, so he was doing his thing over here, and somehow he managed something for communion. And after he was finished and about ready to get going, my son decided he wanted communion also. So he went over and received communion. I don't know what all they decided. We were there for 1 hour. I could take the time. It was over an hour because I was not on a time frame. I was there with a student. I was not under the time pressures that the nurses who visit regularly were there. We left. I tried to explain as best I could what I thought the options were and what we might ask for, and went back to the agency. And in talking with them, we decided to try to get the woman on the hospice team so that at least she could get more care directed toward her, making her comfortable at the end of life. In truth, that's what happened. I forgot about it because I didn't go back again. Didn't go with the students consistently, and actually we didn't go back again to see her. But some weeks later, the nurse on the hospice team was in the office, and she said, "Were you out to see this such and such family?" And I was trying, I remembered. And her words were, they were so impressed that somebody took time to explain to them what the problem was and took their concerns seriously. I truly don't know what the decision was made in terms of Grandma's continuing care. I do know if she's on the hospice team, there would be no heroics, no attempting to resuscitate her, and so on. But this is just one window into one family who's struggling with death, and I have 3 conclusions. First of all, dying is hard work. And it's hard work for a community of people. This was hard work for the family. They were struggling with this big thing. The specter of death was staring them. They were exhausted physically. They felt out of control of this situation. It was very hard work. Also, I think that what people need and what I see as a role of nursing, and other people do this as well, but one of our particular roles is a very practical role. Supporting people, being with them, recognizing the stress. I know from years of experience and having watched my own mother, the exhaustion that comes over months and years of caring for people. Just sheer physical, emotional exhaustion. And I recognized it in this wife. People need education. They need people to speak to them in very practical language about what it is with which they're dealing. And interpreting and explaining, probably not one time, probably 2 times, 3 times, many times, as they're able to hear and take it in, and as they face the next problem. People need help to know what their options are in the face of death. Usually many times those options are pretty simple. They need to know what they are and how to make those next steps. People need linking to personal resources and people resources. They need help to know where to go. They need to know where to go for help. The system is so complicated. Somebody needs to speak for them and build the bridges for them. They need spiritual help. One of the questions I often ask patients and families when they're dealing in stress like this is, where do you get your strength? How do you hang on when life is tough? And often that opens up a whole area of talking about their faith, talking about God. And I know from years of working with people who come from the South and Southern black families who are often linked to Baptist Church, especially older families, that their faith is very real to them. And it's a link to which you can help to draw it in as you're working with them. The third thing is that ethical choices and actions flow out of the character and values of people in the situation. I've often told nursing students, those big-time pull-the-plug decisions, well, I mean, they're real and they're big, but the real rubber meets the road decisions are the little ones that you face in the nitty-gritty of dealing with patients' problems. It grew out, for this family, it grew out of their care and respect for the mother in the family. They wanted her to be treated with care and dignity. They didn't want her tied down at her end. And yet they were concerned and worried that she wasn't getting nourishment and that they weren't doing the best for her. I think that ethical decisions are made in crowded living rooms or busy emergency rooms, but the kind of reflection that we do in places like this helps to prepare us when we're in those situations that we can act almost without thinking many times. This is the next step. This is what we need to do. This is how to help this person or this family in the process of dying. Thank you.
I'd now like to introduce to you Dr. David Schiedermayer. He practices primary care general internal medicine, and he's an associate professor of medicine at the Medical College of Wisconsin, where he teaches clinical ethics on the wards. He was a visiting scholar at the McLean Center for Clinical Medical Ethics at the University of Chicago in 1986 to 1987, and he's the past chair of the Christian Medical and Dental Society Ethics Commission. He also teaches the clinical ethics component of the bioethics program here at Trinity International University at the Divinity School. He's written and co-authored more than 125 papers focusing on the doctor-patient relationship and on ethics consultation. He's a contributing editor to Christianity Today, and he's on the board of the CMDS Journal. He's also co-author of the volume Life and Death Decisions, A Christian Perspective on Medical Ethical Issues. And he's co-author of Ethics Consultation, a Practical Guide. His latest work is Putting the Soul Back in Medicine, Reflection on Compassion and Ethics. He has an interest in missionary medicine. Part of his medical training occurred in Liberia, West Africa, at Elwa Hospital. He recently completed a sabbatical at Tuba City Hospital on the Western Navajo Reservation in Arizona. And even his being here tonight is a special labor of love and contribution to all of us, getting up in the wee hours, driving 7 to 8 hours in a non-air-conditioned car out of the midst of a vacation. Thanks for being here, Dave.
Well, my neighbor, who's a pharmacist, came running frantically across my front yard the other day, about a week and a half ago. She said there's a man who collapsed down at the stop sign, and she said he's convulsing. So I follow her as she runs back down the street, and my family kind of runs along. You know, you got to gather a crowd as you run to these kind of things. Kids on bikes come, and from 100 feet away, I can tell that the man is either dead or unconscious, because just the way his feet are still, his legs are flat, his arms are flat on the ground. He's just laying there in the middle of the street. And as I get closer, I see several people who are beginning to do CPR. And you know, the protocol for that, when that happens, you're supposed to go in and say, I know CPR, and take your turn. So I did that. In a few seconds, you know, I didn't have any masks or anything with me. In a few seconds, I find myself trying to blow air into the mouth of this man, who's got about a half-day growth of whiskers. It's about 1 in the afternoon. It's about right for that time of day. But the air just comes right back at me. It doesn't work like it does in those practice models. It just stops right in his mouth. And it tastes salty. Either he's sweating or he's bleeding. So I reposition his jaw and head, and I sweep his tongue back, and then a little air comes back, so I think maybe there is some hope. And I try blowing in a little harder. Someone else is doing chest compressions. Someone's called 911 from their car phone, and I can hear sirens. I see that the man's eyes are kind of rolled back in his head, that his pupils are dilated, and his skin is discoloring in terms of just the blood is kind of collecting. And I wonder how long it's going to be before he vomits. This is sudden death. A man named Derek fell right off his bike at peak exercise, age 45. And though he's technically dead, we are in the business of trying to revive him. I think I'll take this. As far as I can tell, he's not perceiving any of this, although technically, we're circulating blood to his brain. Unless he's having an out-of-body experience, he's had an arrhythmia either due to coronary disease, which I later know is common in his family, and he just fell limply off his bike. Someone was driving behind him and saw this. Sudden death, and I want to talk about a couple different kinds of death and the experience of death. Sudden death has a kind of amnestic quality. It's kind of an amnesia. I think people actually have a built-in anesthesia. Because as I do CPR, I kind of sense the surreal nature of this thing. The sky is a beautiful light blue. The temperature is a perfect 72 on that day. There's a light breeze blowing. In the background, I can hear the whistle of there's a little train at the zoo. Meanwhile, this man is on the ground on dead. Paramedics arrive. They put in this endotracheal tube, and I assume my favorite position at a code, which is at the person's feet. I kind of like to see if they have a pulse, feel for the femoral artery, and I try to see what's going on. When they come to put the monitor on, they find that he's in ventricular fibrillation, and they shock him twice right on the pavement, and his body just jumps. The spectators gathered by there really wince, and I realize this is the way some people are seeing this experience of death. And there's many experiences of death, and this is a particular kind of violent one. But it works. Its electricity really works. And pretty soon a slow rhythm returns, and I feel a little thready pulse in this man's groin. He begins to breathe on his own, and I get up and talk to the person that was with him on the bicycle. He tells me that Derek rides his bike frequently. He's actually a friend of this man, and I'm not sure if Derek is gay because I find out that they're living together. I walk home and I push Derek's bike while he's being carried off in the ambulance to the ICU. When I call over to the hospital a half an hour later, he's still in the trauma room, and I think that's a bad sign because I think maybe they're coding him again. Some patients die slowly. I remember a patient of mine who survived the Armenian Holocaust and then died in her 80s of thyroid cancer. I remember Anna Velocian. I remember Albert Sosi, who was a Navajo man who died of end-stage renal disease and the complications of diabetes. I remember Mrs. Iona Christensen, who was of Norwegian heritage, a Swedish heritage actually, dying of dementia. When we have time to consider death and these kind of slow deaths, we fear three things about death: shortness of breath, pain, and being alone. Those three things: shortness of breath, pain, and being alone. There's actually an extensive literature on these sorts of slow deaths which require pain control and supportive or palliative treatment and spiritual counsel, the kind of counsel that you've heard about today from pastors and from health professionals like nurses and doctors, from caring people who are in the hospital. Interestingly, in one study of 687 physicians and 759 nurses, 70% of all of the physicians in this study acknowledged that they had violated their conscience when caring for the terminally ill. This violation occurred due to giving overly aggressive treatment rather than under-treatment by a ratio of 4 to 1. So they're violating their consciences and they're being too aggressive. And that was true for the nurses as well. Sometimes pain is not managed properly. Physicians and nurses undertreat with narcotics, although I think this is much less common than it was before the hospice model came. Most deaths can be made tolerable, if not comfortable. And I never promise a patient that they will have a certain kind of death. We can't make these kind of promises because we can't keep them. But we can promise that we stay with patients and not let them suffer alone. Now, some patients are conscious at the time of death, but the burden of disease or the dementia or the cancer has caused them to be less than fully aware. So, for instance, Mrs. Iona Christensen, who was being cared for by her husband, when I went to see her, she could sit up and she could eat, but she lacked bowel control. And so the experience of dying for her and for her family was really, again, the same kind of hard work that you've heard. A lot of turning and cleaning and kind of a slow dying, but a kind of consciousness, though not complete consciousness. One of the first things that missionaries learn, I mean, the experience in the two-thirds world is still the same as it was 100 years ago here, is that the experience of death and decay is common. And a metaphor for me was amputation, actually. I mean, you can die slowly. Part of you can die. One does not have to die all at once. I remember this case. The arm is received in formalin. It is the arm of a small boy, burned and seen under the microscope. Extensive necrotic debris and inflammatory exudate, the gangrene in the arm of an African boy who fell in the fire in West Africa. My first lesson is what you sometimes must needs lose. You don't have to die all at once. Sometimes wounds cause death. I remember one spectacular wound in the patient's abdomen, which actually, the patient had surgery and the abdomen opened up and it went right through to the liver, slowly. The wound was famous. I heard about it, came to see it in the ICU. We kind of objectify dying people so that this person became a wound. Your surgery went well, but the skin edges opened up and fat split open. The muscles grew gray, the fascia opened, the peritoneum opened, and there was the mesentery of the abdomen and the intestines. We can learn from cases like this, I would say. Here is the complication of wound dehiscence after gastric bypass surgery. Too much tension on wounds like this. The wound was now like the basement of O'Hare, the veins and arteries like that pulsing neon on the ceiling. Several weeks passed. I'm sorry to say, you, the patient, never knew, being in coma by now, that the wound tunneled up under and around your liver, which I could see when they changed your dressings, and then broke through the diaphragm and up into the chest. The wound became the means to an end here, the syllabus of a fascinating course held in the classroom of your own person. You didn't volunteer, but your fate was to teach that some things are worse than just unfair. They are catastrophic. They are apocalyptic. You can live through being a good case, but in my experience, very few patients can survive being a fascinating case more than a few days. Part of the experience of dying is the physician's struggle against death. In this era of discussion of physician-assisted suicide, the kind of good death that we sometimes discuss, and I think many will discuss, by far still the dominant paradigm is that physicians struggle against death. Death is always beating us, always frustrating us, and we cannot gain victory over death in the human sphere. Only Christ has conquered death, and we physicians try to slash and suture our way to eternal life, kind of through the bodies of our patients. We personalize death. We dream about death. As those who are close to the dying, at least in some ways close to them, we feel it's our responsibility. We kind of keep company. we feel affected. And Sherwin Newland, who's a physician writing about death, he offers really a moving account of the death of his grandmother, focusing on her physiologic dying of ischemia, which is the way most of us will die, kind of a slow, choking death, the arteries just closing off the various parts. It's a very natural way to go. It's very slow. It's kind of hit and miss. And we see her personality and his relationship with her. But for Newland, there's nothing beyond death. But he is right about death, in that death deprives us of the company of this person. Life is the blessing and the benison. Death is not a blessing. It is a blessing only in the sense of a means. James Andrew Miller, who reflects on his experience with colon cancer, describes feeling first this kind of glittering pain across his abdomen. And he was working on a theology paper. And he was planning to go to Severance Hall to a concert. But there were other plans. He was to die of colon cancer. He writes that he believes in the one who conquered death. And he notes that all of us are somewhere on an unfolding continuum between life and death. Terminal, he calls it, between countries, emigres. Sometimes we escape for a time. I go back the day after Derek's cardiac arrest, and I find him waking up and moving all fours. His pupils are reactive. He will live. He drinks 2 six-packs a day, I found out. He smokes a pack of cigarettes a day. And in speaking to him, I soon realized that he would not be my first choice of a person to save. But that is my problem. God sends the rain, as Paul Ramsey was fond of saying, God sends the rain on the just and the unjust. I asked the cardiologist to draw an HIV. I look at my white coat as I speak to him, and I feel a lot more protected than I did the day that I had to coat him on the street, because I have my white coat on. But my white coat, is a flimsy costume. It's a set of dress whites. Underneath, I see a human body, intricate but prone to disease, adaptable but aging. Nobody's more worried about their body than a second-year medical student. The physician's humanity cannot be covered for long by name tags and instruments and pocket texts and white cloths. My personal fragility links you to me and me to you. All of our costumes are flimsy and temporary, for there comes a time sooner or later when they will all hang empty in the hall closet. Time for a rummage sale. Where can we throw these? When our beliefs will be tested, when we will really determine if there is a resurrection of a body and a life everlasting. Each of us will have a turn. My turn, my experience of dying, and my turn will remind you, and yours will remind me, of what we always and finally have in common.